On behalf of the American Heart Association, I'd like to welcome you to today's Pain and Hypertension Management Summit. My name is Liz Olson, and I'm Director of Quality Programs Management with the American Heart Association. Before we begin, I'd like to quickly review how to use this platform for today's event. Today's live summit features 3 consecutive sessions. Once the session concludes, you will exit and join the next session by navigating to the agenda page. Throughout today's presentations, you'll have the opportunity to submit text questions for our presenters using the Q&A feature. You may send in your questions at any time, and we'll review the questions during our Q&A at the end of each presentation as time allows. Today's slides are also available for download. You can view the slides by clicking on the sessions listed on the agenda page. Lastly, all sessions will be recorded and available within the coming weeks. It's my pleasure to introduce our speakers. Dr. Hee-Jung Choi and Dr. William White will lead our first session, Pathophysiology of Hypertension and Pain Management. Dr. Hee-Jung Choi is an assistant professor in the Department of Anesthesiology at Northwestern McGaw Medical Center. Dr. Choi has special clinical interest in interventional pain modalities and strives to treat the patient through the biopsychosocial model. She's actively involved in the American Board of Anesthesiology as the board exam writer and serves on the Diversity, Equity, and Inclusion Committee. Dr. Choi has also published multiple articles in research journals on the efficacy and safety of pain interventions. She's joined today by Dr. William White, a professor emeritus of medicine and former chief of the Division of Hypertension and Clinical Pharmacology at the Calhoun Cardiology Center at the University of Connecticut School of Medicine. Dr. White has a longstanding interest in clinical hypertension and pharmacology, clinical trials of antihypertensive drugs, the impact of non-cardiac drugs on cardiovascular safety, and cardiovascular outcome trials. He's authored over 500 original articles and numerous book chapters in the field of cardiovascular medicine and pharmacology. Dr. Choi will begin today's presentation, and Dr. Choi, the floor is yours.
Thank you. It's a pleasure to be here today, and I will be talking about pathophysiology of pain and a brief overview of pharmacological treatment of pain. No disclosures for me. So first I'll talk about the pathophysiology of pain, including some of the pain pathways. Then I'll go over the overview of pharmacological treatment for pain. Both of these topics are very large topics that can take a whole day to go over, but I'll strive to provide an overview for both of these topics for you today. So first, I would like to start by going over the definition of pain. The definition of pain is an unpleasant sensory and emotional experience associated with tissue damage. This was the definition since 1979 until 2020 when the IASP decided to add 6 keynotes to the actual definition of pain. All of these keynotes basically surmise that pain is always a personal experience. These keynotes discuss that the pain is a biopsychosocial model, and pain versus nociception or actual perception of pain is different. All the life experiences that the patient has had before the actual pain experiences can interfere, enhance, or alter that actual pain stimulus. Pain should be respected and may not always be a verbal expression of the pain. Just because the patient is nonverbal, that doesn't necessarily mean the patient is experiencing necessarily less pain. It is a very updated and actually hasn't been updated since 1979. So we just need to know that now we're understanding pain as more of a personal experience, which is highly variable and sometimes makes it a little more difficult to study. We'll go over the pathophysiology of pain and how we perceive a stimulus. There's 4 steps to perceiving a stimulus. First is transduction, then transmission, then modulation, and then perception. This is actually a painting from René Descartes, a French philosopher, in 1662. I always found this painting very interesting that he had this idea back in 1662. you can see that there is a fire source of pain, A, that goes to B, where there's transduction or transition of this painful stimulus into a chemical stimulus and a electrical stimulus to B. And then there's transmission all the way from the periphery to the spinal cord. And you can see there was a line up the back to the spinal cord and to the brain, and where the transmission happens all the way up to the brain, and then modulation happens at the level of the brain and the spinal cord. The actual perception, which again is a very personal experience, happens in the brain. So we'll go over each of those steps in a little bit more detail. First step is the transduction. This happens at the peripheral terminals of the primary afferent neurons. There's three major neurons that are used for sensation. First is A beta, second is A delta, and C fibers. The A fibers are thicker, more myelinated, and C fibers are more thin and less myelinated. So therefore, conduction is slower. I actually think it's very interesting that A beta fibers are for light touch, and they actually transmit at 20 meters per second, which in English terms would be 45 miles per hour, or as fast as an ostrich. So A beta fibers are the fastest. And two happens with transmission, where we actually take the peripheral sensory neurons to the dorsal root ganglion in the spinal cord. Second step is to take the spinal neurons to the thalamus, brain, and the diencephalon. And then the third step is to take that from the diencephalon or brainstem to the cortical sites deep in the brain. So there's three primary orders of neurons there. Third step is modulation. Modulation happens in the dorsal horn of the spinal cord, somewhat in the brain as well. This is actually where we can change the perceived nociception or the pain stimulus to enhance the experience or dilute the experience, where you can kind of control your perception of pain. And fourth and last step is the perception of pain, which happens in the deep brain and cortical regions. This is taken from Dr. Benzon's Essentials of Pain Medicine book, and you can see this is updated version of the Rene Descartes drawing. First happens in the periphery, so that sensation gets from the peripheral neurons, the A beta, A delta, and C fibers, into the cell bodies in the dorsal root ganglion here, and it goes to the dorsal horn of the spinal cord here, and it branches off to a second order neuron and gets up to the rostroventral medulla in the brainstem and gets all the way to the thalamus, where the third order neurons branch from the thalamus into the cortex. The other side, you can see these dotted lines where the cortex down to the thalamus, down to the periaqueductal gray in the brainstem, and down, and these are usually descending, modulating inhibitory pathways. And some of them are excitatory, but mostly inhibitory pathways, where we actually call this periaqueductal gray in the brainstem as an analgesic center. It also, interestingly, especially given that this is a AHA talk, that it controls autonomic processes, including blood pressure and heart rate. Rostroventral medulla is another place in the brainstem that is very important for sensation and sensory signaling. And you can see that it has the upward tracts and the downward tract, the inhibitory tracts. And this is where a lot of the modulation happens in the rostroventral medulla as well. We'll take a more detailed look at the spinal cord level. So this is a slice of a spinal cord, and you can see that there is white matter and gray matter. The white matter is the part that's on the periphery, the darker actually place, and then the gray matter is actually this butterfly shaped in the middle. The area of interest in sensation and especially pain signaling is right here in the dorsal horn. you can see that the dorsal horn, it can be divided into multiple layers here, into different rex lamina, as we officially call it. And you can see that the A beta fibers, the thicker, faster fibers, are deeper, and the A delta and C fibers are slower and more superficial. A beta fibers are responsible for light touch. A delta and C fibers are more responsible for pain. A delta fibers are faster. And so that's the pain that you get when you acutely stub your toe, and that hurts hurts immediately. And then the C fibers are what that slow burn is afterwards. You're using gate theory afterwards if you rub that toe, because your A beta fibers are going to mask that A delta and C fibers that are slower. This is a cartoon depiction of different pathways. So you went from primary afferent neurons to the spinal dorsal horn, and then you had all these different tracks to the medial thalamus that go up to the cerebral cortex. Something that I want you to know here is look how many tracks there are on the lower left. The right is the motor pathway. The left is the sensation pathway for the pain. The brain is involved in multiple ways in the sensation of pain. No wonder it is a very personal experience and sometimes very difficult for the patient to express, especially given that it is affecting very deep brain structures that are more primitive. We're going to switch gears a little bit before I go on to talk about treatment of pain. There is biases in pain treatment, as well as any bias that we can do during medical treatment. This is an article from 2020 from Dr. Sabin. She's at University of Washington. This was published by the American Academy of Medical Colleges. And the title of this is How We Fail Black Patients in Pain. We've studied in multiple different ways that the pain in patients who are Black are undertreated and underrecognized compared to patients who are white. The study in 2016 surveyed medical students, and about half of them, or 40% of them, believed that the Black skin is thicker, or Black nerve endings are less sensitive, or that Black blood coagulates faster than the counterparts of white patients. All of these beliefs can lead to implicit bias. Implicit bias is bias that we believe that we don't even know that we have actually. It is in the subconscious, compared to the explicit bias where we know that this is what we believe and this is a bias that we actually accept. And these implicit bias that we don't even know that we have can affect the treatment of pain in patients who are Black or white. There's a 2012 study of pediatricians, and they literally gave the same clinical vignette to the pediatricians. It was about 86 clinicians. And depending on the race of the patient, the amount of opioid medications that were prescribed were variable, statistically significant. The 2012, there was a meta-analysis that was published in Pain Medicine, and the meta-analysis overall concluded that these diversity problems are getting better in the treatment of pain. However, Black patients are 20% less likely to receive opioids and pain medications compared to their white counterparts for the same diagnosis. I would encourage you to go find this article, and there's actually a link onto her University of Washington researches where you can actually test your own implicit biases. I actually think it's very interesting to see what kind of implicit biases that I have that I don't even know about. So we'll go on to talk about types of pain. So in order to treat pain, we need to figure out what type of pain that we're dealing with. First is nociceptive. Nociceptive pain is usually sharp and acute, usually something like a incisional pain. Inflammatory pain is achy and dull, more like an arthritis type of pain. And neuropathic pain, often one of the more difficult pains to treat, is burning, electric, something like a peripheral diabetic neuropathy pain. Figuring out this pain and figuring out whether the pain is acute or chronic, it's cancer-related or non-cancer-related, can help you figure out what type of management will be appropriate. So we'll talk about pharmacological treatment of pain. Opioids, obviously, very debated topic. We will not go into this very deeply, but it is a treatment option. The non-steroid anti-inflammatory drugs are another option for treatment of pain. There's two types, selective and non-selective. And actually, Dr. White will go into this one more in detail, so I'll leave that up to him. And then the other topic is acetaminophen. The mechanism of acetaminophen is still not completely clear. We think that it does COX inhibition in the central system. It's not as clear as the NSAIDs, and maybe it decreases H2 synthase. It is more in the combination drugs. So if you think about the Tylenol, or acetaminophen, the most important thing is not to go too high with the dosing to decrease the risk of liver toxicity. 4,000 milligrams is recommended. I usually recommend 3,000 milligrams a day. The caveat is that a lot of these pain medications come as combination drug with acetaminophen, and you have to add those up as well. Antidepressants are another large category of medication. Tricyclic antidepressants and serotonin norepinephrine reuptake inhibitors and selective serotonin reuptake inhibitors are all antidepressants. These increase the serotonin and norepinephrine in the synaptic cleft and inhibit the pain pathways to the CNS to the dorsal horn. These are interesting in that multiple medications have level 1 or level 2 evidence for neuropathic pains. The tricyclic antidepressants actually have the most evidence, especially the amitriptyline, which causes more side effects, and nortriptyline, which causes less side effects because it's newer. However, the tricyclic antidepressants must be monitored carefully, especially because of the cardiac consequences. They should be getting EKG, and they should be getting QT monitoring. And if they overdose on the tricyclic antidepressant, then the worry is that the patient could go into severe arrhythmia. The serotonin norepinephrine reuptake inhibitors are usually more well tolerated with less side effects, and venlafaxine and duloxetine are usually used. And those have evidence, especially for neuropathic pains. The SSRIs are less encouraged for pain management because they do not have as much evidence for pain compared to the SNRIs and the TCAs. The anti-epileptics are another huge category of medicine. The calcium channel blockers like ziconotide or gabapentin and pregabalin, I'm sure you have all heard of those. Those decrease the excitatory chemicals, including glutamate, substance P, and CGRP, and they are approved for peripheral diabetic neuropathy, CRPS, or complex regional pain syndrome, and post-herpetic neuralgia. Lastly, sodium channel blockers are used for pain, but usually have to be monitored carefully. Carbamazepine can cause aplastic anemia and agranulocytosis. Lamotrigine can cause Stevens-Johnson syndrome. So those are used, but less so. Local anesthetics, another interesting category of medication. IV local anesthetic infusions, such as IV lidocaine infusion, have been used with success with peripheral diabetic neuropathy and post-herpetic neuralgia. But it is IV, it is an infusion that does make it more difficult to use as an outpatient model. So I was involved in this book chapter, and this is the graphic that we came with to make it a little more understandable to figure out which pain medication will be appropriate for what type of medicine. So you can see this is a cancer-related pain. We are more liberal with the cancer-related pain in terms of opioids. So you can see that in the chronic opioids category down here. The neuropathic medications, the antiepileptics and the lidocaine and mexiletine, those are used here. And you can see that the chronic is all medication categories. For cancer-related pain, we had opioids at the bottom here in the chronic, but for non-cancer-related pains, we usually try to avoid that. So that's the difference in the two graphics here. But you can see that there's multiple different categories of medications here, antiepileptics and antidepressants. So that's it for my portion, and I'll actually hand it over to Dr. White, who will go over the pathophysiology of hypertension and non-opioid pain management options. Thank you.
Hello there, this is Dr. William White from the University of Connecticut School of Medicine in Farmington. I'm happy to be here today talking on this topic with the American Heart Association. These are my disclosures, and none of these really are relevant to today's discussion. I'd like to start out kind of like with a dictionary, so we all have the same vocabulary moving forward through the presentation. Of course, we all are very familiar with measuring blood pressure using a sphygmomanometer or digital device. For those of you who are a little bit older, probably remember the mercury column and aneroid devices pretty well. As also, we define the systolic blood pressure as the maximum blood pressure in the vessel, the diastolic blood pressure as that during the relaxation phase, and the pulse pressure is the difference between the systolic blood pressure and diastolic pressure. Now, mean arterial pressure is not a clinical term, but more of a physiologic term, and it's utilized to define the mean blood pressure of the cardiac cycle, and it's defined as 1/3 of the pulse pressure plus the diastolic pressure. Now, personally, in clinical practice, I've been a leader in the field of ambulatory blood pressure monitoring for about 35 years, in which we actually use these little devices that measure blood pressure over the day and night. And the advantage of this is that it gets a true reading of the patient's activities of daily life. We do not any longer use ambulatory blood pressure in hospitalized patients simply because their lifestyle and activities are curtailed according to what's wrong with them. But as you might hear in the news and so forth, it's become sort of the diagnostic tool, a gold standard for assessing drugs, and actually has the ability to get blood pressure measurements during sleep, which you can't really do any other way accurately. This is an example of a 24-hour blood pressure tracing in a person with stage 2 hypertension. I'd just like to point out that how variable blood pressure is throughout the day with activities, stress, medications, and so forth. And then at nighttime, it starts to go down, on average about 15 to 20% in most people. And that actually is associated with less variability. But the nighttime blood pressure is a very, very powerful predictor of cardiovascular outcome. And then we resume with a sort of a surge in the morning when we wake up and get active again, and then the whole cycle begins to set itself up again for the next 24 hours. We also have to keep in consideration what is it that affects the blood pressure. This is a formula that I use in the medical school because it's very equivalent to what's known as Ohm's law in electricity. That is, the mean arterial pressure, or the blood pressure, equals the cardiac output, which is basically affected by blood volume and heart rate, times the vascular resistance, which is affected by constriction of the arterioles. And these are affected by either the sympathetic nervous system or by the renin-angiotensin system, which I'll talk about more in detail. Now, what happens to the blood vessel in people with high blood pressure? Well, normally you've got a certain lumen to blood vessel wall ratio, as shown in this particular picture on the left. As time goes on with the chronic increase in blood pressure, the vascular smooth muscle, which is a muscle, and it creates the muscular media of the artery, begins to thicken or hypertrophy. And as people have high blood pressure for many, many years, the hypertrophy can become more substantial, decreasing the lumen size and increasing the blood pressure. Now, this plays a role in what happens to us as we get older, our older patients and us as older people. The elasticity of large arteries is very, very good when we're young and the vessels are distensible. On this figure on the left, you see a diagram of the aorta, which shows that when the blood column comes down after the ejection of blood from the heart, the aorta has the ability to distend. That slows down both how fast the blood gets out. It also slows down what is known as the pressure wave, which runs along the arterial wall. As it goes down, it hits what's known as the resistance bed. These are very tiny arterioles, and besides going into the arterial resistance bed, the pressure also backs up. It shoots back up the aorta. I know this sounds weird, but it does, and it's called a reflected wave. And when it gets back up into the heart, it creates a little bump, which is the diastolic blood pressure shown in this pressure flow curve over here. So you have systolic blood pressure, and then you have diastolic blood pressure in this particular cardiac cycle. Now, when the aorta becomes stiff from arteriosclerosis, not atherosclerosis, but arteriosclerosis, the speed with which the blood column and the pressure goes down the aorta is magnified. It's much quicker. So when it hits the resistance bed, the reflected wave goes back up even faster than it did before when it was distensible, increasing, guess what, the systolic blood pressure, because that reflected wave of pressure adds to the systolic pressure and reduces the diastolic blood pressure. Hence, this is why you have a widened pulse pressure in older people. So that's why it's not uncommon to see something like 150/60 in an older person. Now you know why it happens. And most of the time, it's very rare to see a high diastolic blood pressure in somebody who's in their 70s or 80s. But the risk of systolic blood pressure continues to be a big deal as people get older. So what regulates the system? Well, there's multiple things. We have the sympathetic nervous system, which is adrenaline and noradrenaline, which affects things in seconds to minutes. We have the renin, angiotensin, aldosterone system, which has an effect within minutes to hours. And we have what is affected by the kidney, which is typically salt and water balance, excretion, and retention, which has effects within hours and days. And these are regulatory systems which remain the major target of antihypertensive drugs. In fact, some of the ways these systems work were actually discovered by drug development and pharmacological probes. So I'll take some of this one by one. This is a diagram of the entire system that I just talked about. Sympathetic nervous system activation, renin angiotensin system activation and release, and aldosterone synthesis and release. So you can kind of think of it like this. Angiotensinogen is a sort of a non-hemodynamic substance or protein made in the liver. Renin, not renin, but renin is an enzyme which cleaves a couple of peptides off of this angiotensinogen and forms angiotensin 1. By itself, it lasts for just literally a matter of a second or two in the system before this enzyme, angiotensin converting enzyme, sounds familiar, ACE, cleaves a couple of more proteins off and forms angiotensin 2. Now, angiotensin 2 does a lot of bad stuff. It causes vasoconstriction, it releases aldosterone, it has direct effects on blood vessel growth and fibrosis and damage, and actually even increases the chances of thrombotic phenomenon. So this system is in play, and the one place where pain in a hospitalized patient will be important is right here, where the sympathetic nervous system gets activated and starts off a cascade, because there's a lot of what we call nerve traffic or communication between the sympathetic system and the angiotensin 2 system. And we'll come back to that in a moment as we talk about drugs. I also wanted to mention, because this is, I think, a very important phenomenon in patients in the hospital when you're taking care of them, or patients in the outpatient area, and that's salt sensitivity. Salt sensitivity affects about half of us as adults, and there's no real routine clinical test for salt sensitivity. I mean, some people, it becomes pretty obvious because they say, well, this is what happened to me all the time. The NFL weekend, people are drinking too much, they're eating too much salty food. They come in to see me Monday or Tuesday and say, oh, I gained 8 pounds over the weekend. I think it's all water weight. And they would have 3+ pitting edema. They couldn't get their rings off, and their blood pressures would be 20 points higher than when I'd last seen them. And sure enough, these were people who were very salt sensitive and got volume overloaded. And it's very common in people with chronic kidney disease, particularly those who have a GFR below 60, people with type 1 and type 2 diabetes, African Americans who typically have a low renin status and actually are much more sensitive to salt in the United States, people who get, let's say, over the age of 60 to 70 years old, the obese population, and those people who are taking chronic non-steroidal anti-inflammatory drugs. Why does that happen? Well, they actually impair PGE2, which is a prostaglandin involved with salt and water excretion. So after about 3 or 4 days of a person taking an NSAID, the amount of salt going out in the urine is impaired by about 40%, and it's got to go somewhere. So it goes back into the system, increasing plasma volume, increasing vasoconstriction, and increasing blood pressure. So over the last, 40 or 50 years, there's been guidelines from the American Heart Association, often in conjunction with the American College of Cardiology, to create a guideline for the treatment and the assessment of high blood pressure in adults. And the last one that came out in 2018, which is, I think, the last one for probably quite a while, demonstrated to the community that the blood pressure of 130/80 should be the new definition of stage 1 hypertension. And therefore, the goal of treatment is to get people to below 130/80. This is no small task, because before that it was 140/90, and it was hard enough, we thought, to get people to less than 140/90. If people don't have a single other thing wrong with them, that is, they're very low risk for cardiovascular disease, that is less than 10% risk in the next 10 years, then 140/90 is considered the diagnostic threshold value for hypertension. And you'll notice that almost every comorbidity that we have in association with high blood pressure also demonstrates 130/80 to be the threshold and 130/80 to be the goal of therapy. Why the change? Why did we have 140/90 for probably close to 40 or 50 years, and then all of a sudden we got down to 130/80? It's because of this study, the SPRINT trial. The SPRINT trial was a systolic blood pressure study done in high-risk people with hypertension. Most of these patients either had vascular disease, chronic kidney disease, or were over the age of 75 to get into the study. It was several thousand patients in the United States, and it was run by the National Institutes of Health. The study involved getting the blood pressure to what was known as the intensive level of 120 or less in the clinical environment, or 140. So that was intensive versus standard. Now, one little important issue about blood pressure measurement, this was done using a digital device with no one in the room. So we call it unattended blood pressure measurement. So 120 with nobody around is sort of like 130 with somebody around. So that's why the committee used 130 instead of 120. In this study, the people who ended up in the 120 group versus the 140 group had a 25% reduction in the primary outcome of all these components: MI, stroke, heart failure, and death. It was stopped 3 years early because this began to be demonstrated so quickly after initiation on the therapy. And you can see here in the blue, it was driven by a 38% reduction in hospitalization for heart failure and a huge 43% reduction in cardiovascular mortality. So they had to stop the study early, and every analysis has been done over the last few years from the SPRINT study sort of corroborates this finding that lower is better. So what if you do have somebody who you think needs therapy? That is, they're over 130 over 80 and they have high risk, or they're over 140 over 90 with low risk. Well, the recommendation is to initiate with a single drug. That could be a diuretic, thiazide diuretic like chlorothalidone or hydrochlorothiazide, a calcium channel blocker like amlodipine, nifedipine, diltiazem, an ACE inhibitor. There's 11 of them, so I'm not going to list them, or an ARB. There's 9 of those, so I won't list those either. So these are all reasonable first-line therapies based on evidence-based results of cardiovascular outcome studies. Now, what about if you think one's not going to be enough? Well, it might not be enough depending on where you're starting and where you need to get to. So if you're starting at 160 over 100, I can almost guarantee you one drug is not going to be enough. But if you're starting about 150, you might say, well, one is enough. But if you're trying to get people down to less than 130 because they have comorbidities like heart disease, kidney disease, or diabetes, probably a fixed dose combination of 2 drugs together would be reasonable. And I always like using a RAS blocker like an ACE inhibitor or an ARB alone, in combination with a diuretic or in combination with a calcium channel blocker. Okay, so changing gears for just a second in relationship to a case I'm about to talk to you about is secondary high blood pressure. In patients with severe and resistant high blood pressure, and a lot of our patients who sometimes come into the hospital with bad hypertension, who might be in a post-surgical situation, or they might be in for heart failure, they might have a pain syndrome along with this. There are common problems, including kidney disease, blood vessel blockage or renal vascular disease going into the kidney, high aldosterone levels, which is a hormone produced by the adrenal gland and causes salt and water retention. We can't forget about common things, obstructive sleep apnea. This may not be detected by people. People may not realize people have this. It's not just snoring. This is actually where people have a reduction or cessation of breathing for a little while. And when they do that, the central nervous system said, you better start breathing fast again. They start hyperventilating, snoring, choking, and that causes a lot of increases in sympathetic nervous system activity. And then, of course, many drugs and alcohol can cause a significant secondary hypertension. Some of the drugs that we actually use for treatment of other things like depression, SNRIs is one particular possibility. Drugs are used for ADHD, NSAIDs, and so forth. So let me present this case to you quickly. This is an 83-year-old patient of ours, a woman who had fairly difficult to control hypertension. She had been taking 6 different medications. She had a history of admissions to the hospital for transient ischemic attacks, for hypertensive urgencies, for acute kidney injury, with a variety of doctors that were before I'd ever seen her. She had a history of heart failure, but she had good cardiac function. Her ejection fraction measured by echocardiography was 60%. And about half the patients that we see with bad hypertension actually have pretty good cardiac function. It's their diastolic function during the relaxation phase of the heart that is impaired, and they end up with the same kind of clinical sort of syndrome as people with poor systolic function. She also had a long-standing history of arthritis of her knees and hips, and she was always in chronic pain in her 80s. She had a diagnosis of poor kidney function with a creatinine of about 2 milligrams per deciliter, but her GFR was much worse than that at 23.9, based on the fact that her age came into play here. So she got hospitalized due to progression of the CKD, the chronic kidney disease. And here's a little diagram. So in September 2017, right at the beginning of that month, all of a sudden she had a creatinine of 3.9, a high potassium, and her blood pressure was 162. See, she had that widened pulse pressure that we talked about from stiff arteries. She was diuresed because she was volume overloaded. She got some furosemide, also known as Lasix. She was kept on her home blood pressure pills, and her blood pressure did not go down. And then a few days later, her creatinine now was up to 5. Her potassium was up, not down, despite the fact that she received a furosemide. And her blood pressures were really quite poorly controlled. So somebody, not me, somebody in the hospital got a great idea at that point. And I didn't know this was all happening, by the way, I have to tell you, but she got an arteriogram. And to cut to the chase, right here, you can see a little catheter. See that little catheter? This is a CO2 angiogram. This catheter is putting in contrast into the right renal artery. And right at the beginning of that artery is blocked. And you don't see any contrast until a little trickle comes back in and reconstitutes it here. So she ended up getting an angioplasty of this blood vessel. And you can see this funny looking material. That's a stent. And the stent is keeping the backbone of the artery open, just like you do in the coronary circulation. And now you got rapid blood flow right back into that kidney artery. So here's what happened. After the discovery of that renal artery blockage, here's what happened to her blood pressure. Came right back down, 140, 120, even way too low. So I had to stop some of her meds, and now she came back up to about 120 again. In fact, about half of her medications were not even ever resumed. Here, they took her off of everything in the hospital because she got so low because of this improvement in her kidney function and the removal of the angiotensin that was in tremendous excess at the time of this blockage. So let's look at this a little bit more closely. This is a study, my study she was in. Before all of this stuff, bad stuff started happening, she had a creatinine of 1.1 when she was in her 70s. She, unbeknownst to us, started taking her Aleve or naproxen at a couple of pills twice a day. She was taking a maximal dose of 1,000 milligrams a day because it helped her arthritis. She got this one dose of an angiotensin receptor blocker, and everything was downhill after that. So there was a very interesting phenomenon here where she was already on an NSAID, then she gets a renin-angiotensin blocker. It's like a double whammy for somebody like her from the standpoint of reducing kidney function. So how does this play out in the sense of the pathophysiology? Well, Dr. Choi already mentioned that there's COX-1 and COX-2. These are cyclooxygenases, and they're the enzymes which are affected by the nonsteroidal anti-inflammatory drugs. They are important in the generation of prostacyclin, PGI2, which is a vasodilator, and prostaglandin E2, which is a good prostaglandin for natriuresis, or the removal of salt from the body through the kidney. So if you give somebody an NSAID, and this occurs within just a couple or 3 days, it doesn't take that long, but at pretty good doses, in somebody who's got kidney disease, diabetes, vascular disease, you're removing prostaglandin E2, and that's going to cause salt and water retention, peripheral edema, and it's going to cause an increase in blood pressure. If you take away the prostacyclin, you're going to get hypertension and high blood pressure and hyperkalemia. So I want to show you one study that I did, which told us that it mattered as to what blood pressure medication you were taking as far as the interaction between the in this case is COX-2 inhibitors, but it would be true for other NSAIDs as well. We took a bunch of patients with hypertension, over 1,000, and we randomized them to get either Celebrex or Vioxx, which was called rofecoxib. It's no longer on the market for you, those of you who are young, but it was around 1998 to about 2004, and it was an incredibly effective anti-inflammatory drug. In red is the changes in blood pressure on the rofecoxib, the more powerful of the two drugs with regards to prostaglandin inhibition, in people taking an ACE inhibitor, a beta blocker, or a calcium channel blocker. So you can see that the patients who were on a renin-angiotensin blocking drug or beta blocker had a significant increase in blood pressure when they got a powerful NSAID. If you were taking a calcium channel blocker, that didn't seem to happen. Why might that be? Well, of course, here the ACE inhibitor works partly through prostaglandins, and now you've removed them. The beta blocker works partly by the removal of renin, and now you've affected that in the system by affecting the renin-angiotensin system through the NSAID. And the calcium channel blocker is just purely a vasodilator. It doesn't care about what happens in the kidney. It still works. So it's something, it was a real learning experience, and this has been proven now time and time again, the interaction between the NSAIDs and the antihypertensive drugs. The last thing I'm going to talk about is the interaction between aspirin and NSAIDs. And this is, believe it or not, supposed to be a diagram of a platelet. I've always felt it looked a lot more like a uterus. But in any event, just quickly, aspirin affects a particular site on the platelet, and it inhibits its ability to aggregate and cause thrombosis. Ibuprofen, in particular, ibuprofen interacts at the same exact place and clogs up this channel so aspirin can't get in there. So if somebody takes ibuprofen before they take aspirin, the aspirin effect is basically nil. And this demonstrated this in this study where when ibuprofen in yellow was given before aspirin, and this is platelet aggregation, you see that the effects on platelet aggregation are greatly diminished within about 6 hours. The aspirin effect is diminished. Whereas if aspirin is taken before the ibuprofen in red, it has its long-term antiplatelet effect throughout the day. Very important for people who take chronic low-dose aspirin for coronary disease prevention. So years ago, and now this is no longer new, but 15 years ago, the American Heart Association had a science advisory on what should patients do with chronic musculoskeletal pain when they have known cardiovascular disease or risk factors based on efficacy and side effects of these drugs from a CV perspective. Recommending initially try acetaminophen because it has less effects on thrombosis, or aspirin. Now, the problem, of course, is not everybody tolerates these medications, certainly not high-dose aspirin, and acetaminophen is better for pain than it is for arthritis. But in any event, that's your first line. And then they recommended you trying to take non-acetylated salicylates the second line, although my rheumatology colleagues say that this is actually not really that much different. Now, at the time, they recommended non-COX-2 selective NSAIDs first, and then NSAIDs that were COX-2 specific, because there was a concern that there was more thrombosis on COX-2 selective drugs than there was on non-selectives. But that has been basically in the last few years dispelled, because the large study known as the Precision trial showed that celecoxib was actually less toxic in a cardiovascular, cardiorenal way than was high-dose ibuprofen. Rheumatologists really feel that their patients with pain have to be looked at on a case-by-case basis, because what works for one won't work for another, and not everybody has these side effects. So there has to be kind of a balance in this risk-benefit ratio. Patients have to be informed, physicians have to be knowledgeable, and we need a lot of treatment options to get everybody under control for their pain and arthritis when they have concomitant hypertension or CV disease. Thanks a lot for listening today, and I'll turn it back over to our moderator.
Thank you, Dr. White and Dr. Choi, for your presentations. We'll now begin our Q&A session led by Roseanne Hemmett, Quality Programs Manager at the American Heart Association. As a reminder, you can still submit questions for the presenters through the Q&A feature. Roseanne, I'll turn it over to you.
Hi, Dr. White and Dr. Choi. Thank you so much for a wonderful presentation. We have a couple of questions that have come in, and especially comments about the wonderful presentation. So congratulations. Dr. Choi, this one is for you. How large of a role does diet play in the management of pain or chronic pain?
That's a really interesting question. There is a discussion of anti-inflammatory diet for controlling pain. It mostly consists of eating more natural foods, more whole foods rather than processed foods. I do think that there is a little bit more evidence for abdominal pain that it might affect, that actually the diet may change the pain. There is some evidence that maybe even supplements, so eating maybe more anti-inflammatory supplements for foods that contain such things as turmeric has some evidence that it may be anti-inflammatory, but none of it is a large randomized controlled study that I can back on, but there is some evidence about anti-inflammatory diet.
Wonderful, thank you. So Dr. White, this question is for you. Many times we hear that folks who have great physical health and they're runners and they're healthy, and yet they come out with hypertension, right? Their diet's controlled, their weight's controlled. Is there a difference in the pathophysiology of folks who have a genetic disposition to hypertension rather than the folks who are dealing with comorbidities?
Well, there might be some differences, but the bottom line is that the pathogenesis of high blood pressure is, in most people is associated with their inability to excrete salt properly. And even on normal sodium diets, there can be that problem, and the salt ends up back in the blood vessel wall ultimately by a variety of very sophisticated mechanisms that increases resistance in the arteries. Of course, if people really, really super restrict their salt intake, they'll alleviate that problem to some extent and probably stave off the development of clinical hypertension for a number of years, but it's not easy to do that. In contrast, it's true that people who have, let's say, type 2 diabetes or chronic kidney disease have an impairment in their ability to get rid of sodium, and greatly increases their chances of developing hypertension. But I saw kids in their 15, 14, 13-year-old ages over my career that before starting to develop hypertension because both their parents and everybody in their family had hypertension, and it was just something that was destined for them to have, and we still had to deal with it and treat it.
Just a caveat to that, Dr. White, do you see that in any specific populations?
Well, in the United States, the chances of getting hypertension is much higher in African Americans than it is in non-Black Americans, regardless of age, and even probably to some extent regardless of diet. And this may be because the ability to handle salt is even worse in the African American population in the United States than it is in whites.
Right. This is the last question here. Is naproxen a safer choice for hypertension patients instead of ibuprofen?
Yeah. So here's the basic thing. I mean, it's a trade-off. Naproxen does seem to have less salt and water retention than ibuprofen at clinical doses that are used for pain and arthritis. On the other hand, naproxen is much more GI toxic than ibuprofen. So if people have a tendency to get ulcer disease or gastritis, naproxen wouldn't be a very good choice unless it was given in combination with a proton pump inhibitor. I think also the individual responses to the NSAIDs vary by person. So, I mean, the ones that are available in general right now include naproxen, ibuprofen, diclofenac, and celecoxib. And celecoxib is definitely safer from the perspective of GI toxicity as well as cardiorenal toxicity, but it has to be given in reasonable doses in order to achieve that kind of efficacy. So I think that's where we fall out on this now. And this was after a 25,000 patient trial called Precision was finally completed a few years ago.
I am going to add one quick additional question for Dr. Choi. Since you seem to be an expert in, especially in cultural bias, what steps would you suggest to mitigate bias from the care of your patients, from your experience?
I think the interesting point is that implicit bias actually is a subconscious. It's not a explicit bias where we understand and we acknowledge that bias is existent. So I think the first thing is to understand yourself and figure out whether you have your own implicit biases. So I think going onto that website and testing whether you have implicit biases would be one of the steps. The other step that a lot of these overarching meta-analysis recommend is to make a more of a protocolized pain management so that there is less provider dependency and there's more of a protocol, especially for pain that is more traditional. It is hard to do this, obviously, because pain is a very personal experience and pain varies. But it is something to consider. There is some hospitals that are working on trauma and figuring out if we can have trauma pain management protocol so that we can be less biased in the treatment of pain depending on the race of the patient or gender of the patient or age of the patient even.
Excellent. Thank you so much, Dr. White and Dr. Choi, for your presentations today. We are very excited to have you, and I'm going to pass back over to Liz Olson. Thank you.
Thanks.
Thank you.
Great. Thank you so much to our presenters. Thank you, Roseanne, and thank you to you, our guests, for participating in this session. Recordings of today's presentations will be made available at heart.org/pain management within the next few weeks. The session is now concluded. Participants, please exit and join the next session by navigating to the agenda page. Our next session will begin at 12 o'clock Central.